Good day, and thank you for joining. I am Sherilyn Francis with the Partnership for Diabetes Health Equity. Together, we can achieve diabetes health equity. At PDHE, we encourage you to connect with us at www.diabeteshealthequity.org, and you can tweet us at P4DHE using hashtag PDHE. The Partnership for Diabetes Health Equity at the Morehouse School of Medicine is a collaboration between the National Center for Primary Care and the Bristol Myers Squibb Foundation around diabetes best practice dissemination and scalability. At PDHE, the bridging of what we call the three elements include clinic, community, and outcomes, where we identify quality team-based clinical care, community engagement, and support driven by data collection and analysis. The cornerstones of PDHE are learn, share, connect. Through capturing lessons learned, case studies, concrete tools, templates, and creating an environment that promotes networking and collaboration, we at PDHE enhance the dissemination of evidence-based best practices that improve diabetes outcomes. And now a few housekeeping measures. As participants, your microphones are muted and shall remain muted through the duration of the presentation. We ask that you check your internet connection because less than optimal internet connection will result in delayed audio and potentially delayed video. There is an icon which um, there is an icon on the slide which represents an image that you will see in the upper right corner of your screen. We ask that you refer all tech issues to the tech support chat pod, and we ask that you refer all presenter questions to the presenter Q&A pod. Please note that there will be periodic stopping points for question and answer, and there will be time designated at the conclusion of the webinar for discussion and Q&A. However, you are free to submit questions throughout the presentation. I now present to you today's webinar entitled Pharmacists as Essential Partners: The Expanding Roles in Clinical and Community Settings, presented by Dr. Sandra Leal, Vice President for Innovation, Syncofia RX, Adjunct Clinical Instructor and Preceptor, University of Arizona, College of Pharmacy. In compliance with ACCME guidelines, the following speaker does not have financial or other relationships with manufacturers of any commercial service discussed in this educational activity. And now the objectives for today's webinar. To explore the role and implementation of pharmacists in the patient-centered medical home, explore new care models involving the integration of community health workers and pharmacists, to discuss the expanding role of the pharmacist in diabetes self-management education and diabetes prevention programs, and to discuss the value of comprehensive medication management in the community and clinical care setting. And now, Dr. Sandra Lee.
Great, thank you very much for the opportunity to present to this group today. I have been very involved in the integration of pharmacists into care teams for a number of years now. I worked in a federally qualified health center for 14 years previous to my current position, and in that model, we really evolved starting a diabetes program that became accredited through AADE and then through the American Diabetes Association. But then also, during that time that I was there, we also participated in becoming a patient-centered medical home. We became a level 3 accredited site through NCQA, and then we also participated in an accountable care organization. So there's been a lot of evolution in the role of pharmacy from away from just the dispensing role to the integration of pharmacists into patient care teams. So I'll be speaking about that today and just giving you some examples of how we've been able to leverage that and how we've been able to justify that role in those models. So this is a definition that I love related to patient-centered medical care, and it's basically that the patient-centered medical home is a way of organizing primary care that emphasizes care coordination, communication to transform primary care into what patients want it to be. And these medical homes can lead to higher quality, lower costs, and can improve the patient and provider experience of care. And I really wanted to emphasize what a patient wants it to be. The goal is really to focus on the patient and enhance their experience, decrease fragmentation in care, but then also show greater value in outcomes and their experience, their satisfaction as they're going through the system. So a lot of times what we see when we have a pharmacist in a model like this, it's that really that emphasis and that focus on the medication use process. What we were seeing before is that that was just something that was sometimes considered, but not usually considered. And with the pharmacist integration into the patient center or medical home, we could start having that set of eyes that really enhances everybody's experience with the integration. So when I think of a pharmacist role, we really enhance collaborative drug therapy management agreements in different settings. So these, we call them CDTMs. They can be used in primary care settings, ambulatory care settings, hospital settings, transitions of care. There's a lot of different opportunities where you can initiate collaborative practice agreements. You can even do it from a community setting in relationship with the different physicians that are prescribing or the different providers that are prescribing within your community. I also think of the pharmacist role in a health information technology setting. I find myself as a pharmacist really utilizing the EHR, using that information to get into more of a population health strategy so we can target specific goals and be able to reach those goals. So we move away from the level of just doing the one-to-one with the patient to really looking at the population and how we can impact that. A big component of this is really targeting patient self-management and engagement. I'll speak about this more with diabetes self-management as an example, but that to me is, again, a great opportunity for pharmacists to enhance adherence, safety, and outcomes. And now there's unique roles that pharmacists are playing in different settings with personalized medicine. One of our models that we have here, and we've started doing pharmacogenomic testing in patients, and we've been utilizing the pharmacist to be able to identify appropriate candidates for therapy, making sure we're doing a full med reconciliation for everything, prescription meds, but then also over-the-counter meds, lifestyle and recreational medication, and being able to look at that and then be able to utilize the results of pharmacogenomics to be able to enhance the experience or the way people metabolize medications to have better outcomes. So lots of kind of up-and-coming opportunities. So some of the critical factors that I consider as I'm working through these integration of pharmacists in medical homes are just the access and continuity of care. When I look at usual care, everybody pretty much understands what the usual experience is for their patients in their practice, but when we start looking at other opportunities for pharmacists to intervene, we're trying to increase the access for the patient in between visits with the providers, and we're proactively looking at population health strategies to reach out to patients. So as an example, if we run a report in the electronic health record where we're pulling people who have very high A1Cs, you can set whatever target that is, then we can proactively call the patient in to address issues around care guidelines, also issues around adherence, making sure people have appropriate lab monitoring, and that's more of really improving the access and the continuity of care. Patient-centered access, we really want the patient to be able to access care how they want to access care, and we want to be able to be available for that. The aspect of collaborative drug therapy management really goes to the team-based care model where you're having different individuals come and assist, and they practice to the top of their license. So, we've collaborated as pharmacists with the medical doctors, with the nurses, with behavioral health, which is now a great integration of that service. But one of my favorite collaborations is with community health workers or Promotoras de Salud to be able to reach out into the community more than just staying within the clinic walls. And I think that enhances the whole model of care and access and reach for patients. Culturally and linguistically appropriate service is, again, a very key component that we focus on, always looking at things like health literacy, language, and making sure that we're definitely having impact on patients in the way that they need to have communication for them. I already spoke a little bit about population health management, and then I'll be speaking a little bit about medication management as well. But this is one of the things I think about with the way you get patient-centered medical home accreditation. There are some components of the report card to be able to reach PCMH that are very specific and where pharmacy can contribute. I just happen to pull one here for meaningful use alignment and PCMH alignment. You can crosswalk a lot of the rules that pharmacists have with some of the elements that are required. So in this specific critical factor that you must submit These are the things that have to be occurring. So medication reconciliation, managing medication, and there's very specific criteria and components to be able to do that. So as you're trying to leverage a position, what I like to do is look at the requirements for either meaningful use, for HEDIS, for PCMH, and crosswalk the different elements where pharmacy can enhance that. And so everybody has a role to play, but when you really start looking at roles to justify these positions, that's a great way to leverage that. There's also other alignments with other goals and measures to help justify these positions. So when I looked at a pharmacy-specific position, to be able to do that, I looked at disease management goals. So you can see these listed here. Things like HEDIS measures that you're trying to target, influenza vaccines that you can utilize, different admission and COPD admission scores that you're trying to reduce. But then as I'm trying to look at revenue generating opportunity, I'm looking at codes where pharmacists can also generate revenue upfront to justify the position, but then also help with the outcomes, especially if you're having risk-based contracts where you have to reach certain markers. Otherwise, you either get penalized or you don't get a bonus necessarily. So in an annual wellness visit, for example, pharmacists can actively participate in performing those. And things that pharmacists are able to do aside from the medication management piece, which is a critical component, but we also help coordinate care, making sure we're reinforcing care guidelines like breast exams in women, again, vaccination rates, screenings for blood pressure, for BMI, cervical cancer screenings. But then we're also doing population health management at the same time, looking at more of the reporting and being able to proactively reach people to be able to reduce some of the admission or utilizations that are not necessarily what you want, like ER visits. So I, again, look at these alignment with goals and measures and try to crosswalk the roles that pharmacists can play in order to hit these metrics. And that's how I justify these positions to our C-suite as we're trying to get more, more support in these models. So I mentioned earlier how one of my favorite relationships is working with community health workers. I just wanted to give you an example of a couple of different projects that we're working in, and I think this really provides room for innovation. When I was working at the Federally Qualified Health Center, we would utilize the community health workers to help schedule the classes for diabetes self-management, both locally in the clinic, but then we also scheduled classes in the community library, and they were the ones, the community health workers, that would go out and recruit for us and really fill those classes up, which was great. This poster that I'm showing now has a different example where we actually use community health workers in rural communities, and we use more of a telephonic model. Some of the rural communities can't necessarily either recruit or afford a pharmacist on site, but we were still able to provide that service by being able to have a community health worker relationship where that CHW would go into a patient's home and then coordinate with the physician, and they would have us on call. They'd call us, we'd be doing a review with them when the community health worker was at the patient's home, and then as we were trying to make recommendations, they would also help the patient have that communication with the physician so that our recommendations were accepted. So this poster was presented at the American Public Health Association conference, and we definitely saw an improvement in drug therapy and safety with the recommendations that we were identifying as we were partnering with the community health workers. Another example that we're launching is using community health workers to help recruit people for vaccinations. This is more of a community setting where we have a pharmacist in a retail setting that partners up with a community health worker, and the community health worker essentially goes out and lets people know that these vaccinations are something that they can access at a pharmacy, that they're available, no appointments are necessary, and what we're trying to do is improve access, improve public health, and then hopefully create some of that community connection. So we're not practicing just within our healthcare walls, but really reaching out into the community where we need to access people. So some of the things that I think about with pharmacists in the DSME or DPP models are twofold. Pharmacists can actually deliver care. Pharmacists can be a credentialed provider for DSME, and then they can actively participate in education and diabetes prevention programs, or they can help recruit for both. But really, diabetes has so many comorbid conditions that require a lot of medications, definitely a lot of chronic medications. So, when you think of diabetes, you're probably thinking about hypertension, cardiovascular disease. A person could have other coexisting conditions like asthma and COPD, heart failure, adherence issues in general. And so the pharmacist can really play a role in that. And I wanted to show you an example of a couple of scenarios where this plays out so you can kind of get a feel for what this looks like. But one of the exciting things we're seeing is that the recognition of the pharmacist in this more clinical role is now starting to be recognized by national and local authorities. So an example are some of these publications here that are really starting to show the impact of integrating pharmacists in an effective healthcare team. So we've had publications in diabetes care, we've had publications in JAMA, in different systematic reviews and meta-analysis that essentially have looked at the literature out there on the pharmacist role in different chronic conditions. And what we have found very consistently is that there is a significant return on investment depending on the condition. But we've seen anything from $1 invested to $3 for a specific condition to up to $1 invested to $20 return. It depends on what the conditions and what the medications are. But consistently, we see an ROI for this model. So again, if you're not familiar with how to justify one of these FTE pharmacy positions, there's now a lot of literature that supports that. And then again, crosswalking into some of the accreditation opportunities can help justify these new and expanding roles. This is a scenario for what a typical encounter would be. And I just picked diabetes again because this seems to be one of the most common areas that pharmacists are having impact in. But if you have a typical patient, 62-year-old woman with diabetes, hypertension, hyperlipidemia, presents with an A1C of 10.5, high blood pressure, 158/95. They have symptoms of frequent urination, thirst, concerns about cost of medication. The typical thing would be that this individual would go and see their provider for possibly not even for diabetes, but maybe they're coming in for UTI because they have high blood sugars. So the doctor identifies that the patient has uncontrolled diabetes and needs insulin. She really doesn't want to start insulin, so an oral med is started. She also starts a blood pressure med because her blood pressure is high, and then the follow-up appointment is scheduled. So 3 months later, the patient will come back, and things might happen during that 3-month period that might cause a problem for the patient. So an example of this would be that she might have never even picked up her medications because it might have not been covered or the copay was too high. Or if she started a specific medication, she might have experienced a side effect that made her stop taking the medication. So at the repeat A1C, you actually see a worsening of the A1C, 11%, versus what she started off with 10.5%, and blood pressure is essentially the same. So again, she's presenting for a UTI. So these are the kinds of scenarios that we see, and it's not, to say that the doctor didn't do a great job, because you can see from his recommendations that they did prescribe, they address the concerns of high blood sugar, they address the concerns of diabetes, but yet the appointments might be a little bit infrequent to be able to get this person to go. So in the different scenario, what we end up doing is we plug the pharmacist into this usual care model. So you essentially have the same experience, but in between the visits, now the pharmacist is essentially helping to titrate the insulin that the doctor recommended and reinforcing what the doctor wanted this patient to do. What we identify is that the pharmacists, as they're going through it, they might address the issues around access. Maybe the patient who couldn't afford the blood pressure medication, when they sit down with the pharmacist, they're now able to make a different therapeutic recommendation or something that's on formulary. Or if there's an access to medication issues, we can make different recommendations. There might be a discount service that we can offer so that the patient actually has the ability to have access to those medications. Again, if the patient experiences side effects, we can address those or maybe recommend a different medication or figure out ways to titrate more slowly so that the patient doesn't have side effects that lead to discontinuation. So as we're plugging these visits in between the provider visits, now the patient has more access. They're able to identify issues that are happening, but we can address them proactively. And over time, we might see the patient maybe 1, 2, or 3 additional times between the appointments with a physician. And the goal is to really get that person to a blood pressure goal that's at the recommended for diabetes, and then the A1C improve over time. So what that does is it actually ends up opening up the appointment when the doctor sees this patient again. So now what we're doing is we're allowing the physician to focus on more preventative care concerns and other concerns, because they're not just having to deal with the high A1C or the high blood pressure. They can address preventative issues around screening and be able to make other recommendations. So the physician ends up being happy that they have a more productive visit. the pharmacist is put in a role where they're really being able to use their clinical skill sets, and then hopefully the patient is actually experiencing a more proactive approach, more access, more ability to afford their medications and get their situation and their concerns addressed in more frequent periods versus having to wait for that next follow-up appointment. So some of the ideal settings for the pharmacist can go, I always try to think about it as local and more, and then the more expanded role. So the more local role that I think of a pharmacist is doing more of the direct patient care or the disease management, the visits in between the doctor, like I just discussed. But then there's also other ways that the pharmacist can participate. They can do the visits, they can do Medicare annual wellness visits. They can also participate in patient care encounters through the incident to billing model. So that again provides that initial revenue to get this opportunity going. But then there's other ways that the pharmacist can participate within the organization. So there's a non-direct patient care opportunities, and these include things like being able to consult with physician groups, do a lot of education. I know that a lot of the role that I used to play in the clinic was to do guideline updates for the providers. We would look at prescribing trends and be able to recommend, different things based on either new guidelines that come out, new evidence, cost issues, safety concerns, just to keep the practice up to date. We would, again, do population health management, like we would look at specific reports where we could proactively reach out to patients and then help the workflow around that and design a program that would impact those quality report cards. And then again, we would look at safety issues and improve prescribing practices. There's some really hot button items that we definitely respond to. Like, I know everybody's talking about opioid prescribing. That was an area that we would proactively take a role in and be able to identify ways that we could improve that and to minimize, the issues around abuse, making sure people had appropriate prescriptions and things of that nature. From an administrative level, there's a lot of roles for pharmacy in that as well. One of the roles that I had the privilege of participating in is strategic planning. How did we roll out new services? How do we incorporate different members of the healthcare team to be able to maximize the resources we had? Because there's so many limitations on resources, we were able to stratify, how we would target different groups and different objectives. Again, the IT component is a very critical element, both from a prescribing standpoint and utilization of the EHR, but then also using quality report cards and quality reporting. And then again, targeting different accreditation standards. I know personally, I sat on the Joint Commission accreditation group, and my area was the National Patient Safety Goals. A lot of the National Patient Safety Goals revolved around issues like anticoagulation, safety around monitoring, different aspects of that I could actively participate in. So you can leverage this position in many different ways to impact your overall clinical functions. So just to give you an idea of how these different models have progressed, pharmacists have really evolved in the last few years. There's been a big push to have provider designation for pharmacists. One of the things that has been a limitation for pharmacy historically is that we are not considered healthcare providers in the Social Security Act that essentially identifies who can bill under Medicare or CMS. And what this does is it creates a limitation where pharmacists are trying to be placed into these clinical roles. So there's been an active push on a state level and on a national level to have this provider recognition. So what's been happening, the way pharmacists have traditionally been paid is through dispensing. But when you're putting a pharmacist in a clinical role, they might not even, practice in a pharmacy. There might not even be a pharmacy within any footprint within your health center. So what we're trying to do is take the pharmacist out of the pharmacy and put them in a role in a team where they're actively influencing prescribing in a positive way, making sure that the prescribing is happening, that good prescribing is happening before the prescription is written, during the time the prescription is written, and then after the prescription is written with great monitoring. So the state of affairs right now, state level provider status has increased. There are 38 states now that have provider designation, 36 in state statute, and then 9 in Medicaid. So when you have that provider status in different levels, it allows you to bill under certain conditions. Collaborative practice agreements have really expanded as well. There are 48 states now where pharmacists can be in collaborative practice agreements with different providers, and this can include MDs, nurse practitioners, PAs, Essentially, what it is it's a collaborative model where the physician can write prescriptions, they can order labs, they can initiate therapy, but again, it's in collaboration with the providers in that practice. So the states are now allowing pretty expansive collaborative practice agreements, and this allows for things like pharmacists being able to vaccinate. There's a huge push to have pharmacists have the ability to prescribe naloxone because of that opioid epidemic I mentioned earlier. And then there's also, you've probably heard in the news different things about pharmacists now being able to prescribe oral contraceptive in some instances with some specific collaborative practice or some specific criteria. But this all speaks to the ability of improving access and continuity of care for the patient. So these are some of the statewide protocols that are now being allowed and really expanding. Naloxone is pretty much picking up in many, many states. Immunizations, I think every state now, 50 states allow pharmacists to immunize for flu vaccines, for pneumococcal vaccines. And what's happening in the immunization world is that now there's also the ability to vaccinate children, and the number of vaccines that pharmacists are able to prescribe are now expanding as well. So it's really impacting in a positive way vaccination rates. There are very active smoking cessation programs that are occurring. Again, I mentioned oral contraceptives. I know in Oregon recently this law passed where pharmacists can prescribe hormones. They do have to check blood pressure and they do have to communicate that with the physicians, but that's improving access. And then pharmacists are able to give travel vaccinations. So a lot of positive things that pharmacists are being able to do, again, to improve access. One of the things I think about, and one of the reasons I became a pharmacist was because you can essentially access a pharmacist without an appointment. I mean, you can go to a pharmacy, walk in, and have the ability to communicate with a pharmacist if you reach out to them. There are so many visits to the pharmacy that you can literally go in at almost any time of the day now. There's some pharmacies that are 24 hours, 7 days a week. So this is probably one of the most accessible providers. One, because of no cost to walk in and reach this individual, but again, because of the number of pharmacies out there and the ability to just walk in and have a question addressed. These are some of the states that have developed some payment models for pharmacy. The ones that have a star have some kind of payment, but these can be payments like a pay-for-performance agreement that's established in the state. There are some Medicaid plans that pay for specific pharmacy services, some Medicaid MTM programs or medication therapy management programs, and then there are some states that allow state employee MTM programs. So the state might contract with a pharmacy group to encourage chronic care condition management like diabetes management or even health and wellness programs. So pharmacists are doing screenings, vaccines, things like that for state employee groups. So again, really providing more of that access and outreach to care. This is a bill that's happening now, which is very exciting for pharmacy. There are two bills right now in Congress. One is the Senate bill, and then the companion bill is a House bill. And it's Senate Bill 314 and House Resolution Bill 592. And basically, this is called the Pharmacy and Medically Underserved Areas Enhancement Act. What it's doing is it's allowing pharmacists to get that recognition as a provider in medically underserved areas and in areas that have health professional shortages. So the House bill has 287, and I think that might have gone up since I typed in these numbers. The Senate bill has 47 support now. So the House bill is well in the majority, and the Senate bill is very close to majority. But the goal is to get this bipartisan effort to pass, which would then allow for pharmacists to be recognized for their clinical service versus the dispensing of medications alone. So this is exciting because it's really targeting medically underserved areas that already might have access issues. So trying to really enhance that access in those areas. This is a great report from Avalier Health. They basically put together a report on pharmacy organizations' value and pharmacy project. I really recommend if you're thinking about having pharmacists participate in a team to look at this report, because what they did is they essentially compiled a list of articles in support of this model where you integrate the pharmacist into the care team. They really looked at different opportunities that I've already mentioned, but things around medication management, med reconciliation, preventative services, counseling, the whole collaborative practice model, and they compiled a report that gives very specific information that you can utilize to leverage these positions. I refer to this document because it's just a nice compilation of a lot of the things that I've already mentioned. So, you know, why is pharmacy so important and why should we not be overlooking it? This is one of the statistics that I think is going to continue to influence the value of pharmacy. There are more and more people with multiple chronic conditions. So these are the percentages, but, you know, people with a 0 to 1 chronic conditions, 32%, 2 to 3, 32%, 4 to 5, 23%, and 6 plus conditions, 14%. Medicare enrollment is expected to grow tremendously. You know, they're saying about 10,000 patients a day for the next 20 years. And we know that, you know, people who are older tend to utilize more medications, prescription medications. So when we have people that are aging with multiple medications, with multiple chronic conditions, it's really an opportunity to leverage that pharmacist and the care team to enhance the work and the care that you're trying to provide for them. I see this, there's problems, there's so many medications being used, but opportunities for pharmacy. This is an example of one of the statistics that really surprises me, but it's not surprising, but it is surprising. Nearly 70% of Americans take at least one medication, one prescription medication, and more than 50% take two medications. So again, a lot of people taking medications, but 50% of people being prescribed medications for chronic conditions do not take their medications correctly. And it's complicated. The reasons might be multiple factors. It might be things like they didn't understand access to care issues, affordability issues. They might be taking over-the-counter medications that have interactions with their prescription medications or herbal medications. So there might be a lot of competing factors. And again, this provides an opportunity for the pharmacist to participate in that role and really help have better outcomes. So what I really wanted to do is leave time for questions because I know that we've done similar webinars and I feel like there's so many questions people want specific answers for. So we left a little bit of time to have those questions answered. And so I'm going to open up the floor here and see what questions you have and what I can offer as resources for this. I see a question here. How are pharmacists becoming involved in DSMP? Are they hosting or referring? If they are hosting, so most of the work that I've seen around diabetes prevention has been around referring. We partnered here in Arizona with a YMCA, and they have a very specific referral program. So what we ended up doing is we disseminated what that referral criteria was for diabetes prevention. And the pharmacists were helping either the rest of the provider groups identify patients or directly referring into these programs. And what we found is because we have access to a large group of people that are either coming into the pharmacy or into the pharmacy care areas, that we were able to help in leveraging and helping people, influencing them to go into these prevention programs to have the ability to increase enrollment in those different programs. Any other questions that we have?
So we do have a question from Grace. It says, can you expand on the role of pharmacists in smoking cessation/tobacco use treatment?
So we've got a couple of different ways that we can do that. Definitely addressing, like pharmacists can be active in providing care around smoking cessation, both in a community setting and in a clinical setting. Like pharmacists can actually have specific clinics that are designed for smoking cessation. In the company I work for, Symphony RX, we've designed a program where we do telephonic outreach for smoking cessation, and we partnered with the state smoking cessation program to be able to identify people that smoke and then help in counseling and reinforcing cessation. We also help patients identify what products would be good for them based on their needs and based on what they've tried before. So we're able to essentially work with them to answer their questions about different cessation products, and talk about what the benefits are, what side effects might be. We can talk about costs and alternative options for them. So you really can use a pharmacist in different ways, either direct counseling, direct visits to see them for smoking cessation, to do outreach, and then education about product selection and reinforcement. So those are the different types of roles that you can embed a pharmacist in doing in this specific model.
Question. Do you have any insight or thoughts on the role of pharmacists in the National Diabetes Prevention Program? It's actually a two-part question. And do you think they are better positioned to test for prediabetes versus referring to the program versus, we'll just start with the first part. Do you have any insight or thoughts on the role of pharmacists in the National Diabetes Prevention Program?
I mean, there's definitely a lot of roles that pharmacists can play in that, in both in referring to programs that are already established or in helping to essentially collect some of the data that's required to show value in those programs. Like a lot of them require screenings, checking BMIs, potentially checking some labs and things like that. And pharmacists can definitely enhance that. When we partnered with a YMCA, they had a very specific criteria. So what our pharmacists did is we identified what the criteria was, made sure it was an appropriate candidate. If they needed certain either lab values or blood pressure or weight measure sent in, we would send it proactively. So that was a way to participate. Sometimes I know the curriculum for DPP is pretty specific, so you can't really deviate from that. But there are aspects of it that the pharmacists can reinforce or enhance. So in the diabetes prevention program, again, if there was a specific area that they needed education or reinforcement around medications, adherence, vitamins, supplements, things like that, the pharmacist can play a role in that. So you can essentially leverage, there isn't like a cookie cutter approach to it, but if you have those resources, the best thing to do is to communicate and collaborate and see how you can enhance each other's programs or even embed a pharmacist within a program to help that model. In the DSMT program that we manage for actual diabetes management, the pharmacist was the credentialed DSMT provider. But again, we could also serve more as a referral. So it just depends on what your resources are in your community, sitting down and collaborating and then figuring out a way to be able to enhance that model that you have.
Okay, wonderful. We have a question from Chris, and we encourage all participants to submit your questions in the presenter Q&A pod so that they're not mixed in with the tech support chat pod. Can you speak to the role of pharmacists in blood pressure control, particularly in underserved rural areas which may not have primary care physicians or an abundance of primary care physicians?
Yeah, I mean, definitely pharmacists can play an active role in screening people and checking blood pressures. One of the things that I really like about pharmacy, again, is just the ability to access it, especially in rural communities. That might be one of the few providers out there. And the bill that I spoke about is really trying to enhance the role of pharmacy in underserved and populations that have, or in areas that have health professional shortages. But pharmacists have been active in screening for blood pressures. Again, if you have a collaborative practice agreement, pharmacists can actually titrate medications. They can help prescribe new medications. It just depends on the setup for that. But pharmacists, they have the ability to do the blood pressure screening. They have the ability to educate around adherence if that's an issue. If cost is an issue, we can make recommendations around alternative agents that would still have the therapeutic equivalent or the therapeutic benefit, but might be more affordable. So when you think of pharmacy, think of them as an advocate for the patient and an access point to the patient that might not normally think about, but that is available there. One of the big things that we did with HRSA not that long ago was we did this patient safety collaborative where we essentially integrated pharmacists in many safety net organizations, and those pharmacists were essentially expanding their role to try to serve some primary care needs that were not being served because just sheer lack of providers. If you don't have enough providers in your community, your appointments might be less frequent. So having that pharmacist to provide some continuity of care is very, very critical. We also leverage things like relationships with colleges of pharmacy. If you have limited resources, some of the benefits of having a relationship with a college is you can bring in P1, P2, P3, P4 students. So these are first year to fourth year pharmacy students, and now residents. We have pharmacy residents in levels 1 or 2 that can also be utilized to be able to do some of these more advanced clinical training roles. And they're all supervised by pharmacists, but what they do is they expand the opportunity for pharmacists to be able to see patients in a more clinical role. So if you have a need like that, or you want more blood pressure screening, just kind of evaluate what the resources are, talk to the pharmacist, and then figure out if there's a way to start like a half-day clinic or a 2-hour clinic once a week just to get that started, and then figure out ways to expand that based on the impact it's having.
Thank you. In states where pharmacists are not recognized as providers, can they still bill for annual wellness visits?
So the annual wellness visits can be billed because that's a Medicare bill, so it's for CMS, so it's a federal code, so it's a CMS code, and it is not a medical visit, so it's a wellness visit, so it's more of a prevention encounter. So even though the pharmacist might not have provider status in that particular state, because this isn't a medical visit, it's an annual wellness visit that's preventative, the pharmacist still can do those elements of that visit. But again, it's only limited to Medicare patients, and if they were to do any other kind of encounter, like an incident to encounter, then you would have to really go to the state scope of practice to see what the pharmacist is able to do within the state scope of practice. So there's very specific nuances in it, but for the wellness visits, because they're more of a preventative, more of a counseling and education encounter and screening encounter, that's typically not a problem.
Okay, our next question. Can you think of or do you have any examples of success stories where pharmacists and community-based organizations have developed a bidirectional referral process?
Yes, so there are a lot of different examples that are going on in the community. Well, one of the things that I think about immediately is if you've ever heard of the 340B drug pricing program, it's essentially a program that creates discounts for patients who fall under safety net organizations. And there's a lot of contract pharmacies that provide that outside of the clinic setting or the physician group. So if you look at a 340B program contract pharmacy, what I've seen is a lot of examples of where the community pharmacy that's partnering with that entity for the 340B drug pricing program is also starting some relationships to build that community setting piece where they're doing some more additional screenings or relationships with the providers in that group because they're already having to communicate around the 340B program. So that would be one way to do it. But in other examples, we have some more independent pharmacies that have actually reached out to specific provider groups that send a lot of prescriptions to them to do things around specific care areas, like maybe offering diabetes classes for those patients, or being able to do some education, or come and do some actual visits within the practice. There's a couple of pharmacists I can think of that have very advanced collaborative practice agreements. They're more of the retail side, but they're collaborating with physician groups to actually provide clinical recommendations, clinical services, or do on-site visits. The other examples that I think about all the time are colleges of pharmacy. The faculty end up having to find a practice site where they can deliver care, and so they'll partner with physician groups to be able to set up relationships for that. One of the examples that I use and that I'm doing right now is I'm actually in my company, we're doing a transitions of care program where we've partnered with a local hospital who's part of an ACO, and we do telephonic calls to patients who have been discharged to avoid medication errors and issues around the transition to prevent readmission. So again, there's so many ways that you can leverage the pharmacist in different models of care. It's just really figuring out what your needs are and what you're trying to address, and then being able to design a program around that and just have that expertise brought to the table.
I have a question from Patrick. Has there been any consideration in your work or across various states to engage to engage schools of pharmacy to integrate PharmD students supervised by licensed PharmDs in the clinic setting, community pharmacies, and community events to increase medication, sorry, to increase medication? I would go with compliance.
Yes, I think most colleges and pharmacies now have that as almost as a requirement to be an accredited program, to create those community relationships. I could tell you, I'll just speak from the experience here at the University of Arizona. Our pharmacy students are placed in both what we call the IPP and the APP rotations. This is like their rotations in the first year of pharmacy school and in the fourth year of pharmacy school, where they're placed into different opportunities to be able to practice or shadow and learn from that experience. We have a ton of different health fairs that we conduct in nursing homes, in different community groups, in different community partners, where we're able to screen people for BMI, blood pressure, DEXA. We do like some DEXA screenings, different types of tests that we can do, blood sugar testing, either A1C testing or finger stick testing. But we really leverage the students to be able to get into those areas, do more expanded role and more expanded experiences, and be able to leverage that. Now, from a physician group or from a entity, that's a great resource because you don't necessarily have to pay the students. It's part of their training So you can leverage that and really increase your ability to scale because it's not necessarily costing you anything to bring these individuals. You just have to create that relationship and be able to participate with them.
Thank you. We have a few questions for the Partnership for Diabetes Health Equity. So we also have Ms. Jackson, who's the director of the PDHE available. And so we'll field a few PDHE related questions. First question.
Hi, everyone.
For Ms. Jackson, how can I, as a pharmacist, work collaboratively with others within the Partnership for Diabetes Health Equity?
Okay, can you hear me okay?
Yes, ma'am, we can hear you quite well.
Okay, awesome. Thanks, everyone, for attending. I'm so excited. Thank you. So, how can pharmacists join PDHE? So the partnership is a really good opportunity to connect, learn, and share. And Sherilyn, she alluded to some of this in the opening, that we are here really as a community and as a resource. So attending this webinar, downloading free resources, reading our newsletters, and becoming members of our virtual community are all available to you. And so that's what we are offering, that we'd like to engage you to become a part of what we're doing here.
Okay, wonderful. We have another question for Ms. Jackson. What are the incentives for organizations who choose to work with the Partnership for Diabetes Health Equity?
Okay. Thank you for that question. I feel like it's like a beauty pageant. So thank you for that question. So the incentives for participating with PDHE actually can run the gamut. Of course, we offer, right off the bat, we're offering the free CE accredited webinars and training, be they via live offerings like we have now, as well as the courses that we have in our LMS. We also have tools and templates that you can download free of charge, and the beauty of that is that they're contributed by boots on the ground contributors. And for those of us who are out here in the space of dealing with patients with disparities and the desire to achieve health equity is your goal. You know that it is very important to have real-world examples of things that are practical, that have been tested, and you know that you can apply them. And so I think that's one great incentive that we offer. And also the opportunity for peer learning and sharing. I think that that's valuable. Some of you may know that we are now operating a 12-month learning collaborative. And unfortunately, that opportunity to join has passed. We are well into half a year, and one of the things that the teams are able to benefit from each other is the peer learning and sharing. And that is something that we hope to duplicate through our online virtual community. Some of you attended an event we had a month or so ago where we launched that pharmacy workspace. And the idea is much like we see happening all over the country, where people are forming these virtual communities, and it's an awesome way to connect, but it's also a way to support and to share ideas and just practical help. And so I would say that that is, in my opinion, a huge incentive for participating. But also for those of you that are organizations and you bring resources, tools, and templates to the table, then this, our project, our website, diabeteshealthequity.org, we are looking for best practice stories to share and to disseminate to others. And we're also looking for tools and templates and resources that maybe your group has developed and it's working well and you want to get that out there. We're also looking for partners who want to promote what they're doing in the space of health equity and also partner with us to get the word out about trainings and live webinars. So there's a lot of mutual exchange that can happen, as well as this can be an opportunity to provide more visibility to the good things that you guys are doing as well.
Very much. So, and we will continue with questions. If you have any more questions for the Partnership for Diabetes Health Equity or Dr. Leal, we encourage you to continue sharing those questions. Our next question is from Dr. Holloway. He begins with, thank you for a wonderful and educational program. Are you aware of how pharmacists have parametrically shown to reduce disparities to medically underserved areas? I have read about how Dr. Chen at the University of
Southern California has published data.
Yes, and actually, that's one of the it's one of the exciting programs that was funded through the CMMI grants, so the Innovation Center through CMS. The Innovation Center actually awarded several grants that included the pharmacist role in those models to show the impact. So I know that Dr. Chen is one of the ones that received at USC, University of Southern Cal. He partnered with federally qualified health centers in the California area, and it was a number of health centers. So he's publishing those results through that CMMI initiative. There's a number of other practice sites that did that, and so there's actually a publication that compiled all of these different results. I could send it through maybe I can send it to you, Sabrina, to disseminate with the group, but it essentially compiled the different groups that did these different studies in these underserved areas to show the impact. Another big project that we did was through HRSA. It was a Health Resources Service Administration, and they did a patient safety collaborative that lasted, I think, almost 6 years. And they put out a couple of reports through one of their, I want to say their research groups. It's Mathematical Policy. If you Google HRSA Clinical Pharmacy Demonstration Program, they essentially compiled all of these different sites where they showed the impact of pharmacy. And then the other one that I think of off the top of my head is the American Pharmacists Association Foundation. They did a pilot called Project Impact Diabetes, where they compiled the data of 25 underserved sites. They essentially rolled out that same model where they had pharmacists in underserved populations in 25 different areas around the country, and they showed a very statistically significant improvement in the metrics that they were monitoring, which included A1C reduction and then targeting lipids and other conditions associated with diabetes. So that's the American Pharmacists Association Foundation, and you can Google Project Impact Diabetes for that publication, because that was actually published with those results. So there's numerous examples out there. The United States Public Health Service Corps compiled essentially a meta-analysis of the impact pharmacy has had, and they also compiled a very, very significant report which showed the ROI based on each chronic condition. So that report was presented to the Surgeon General in hopes that it would help, influence the policy to show that when you integrate pharmacy services into these models in this type of manner with a clinical integration, that you actually have an investment and a return on investment for the role that pharmacists can play in those models. So there are numerous justifications or evidence out there for that.
Thank you. Next question. Can you please suggest how health educators can help motivate/transform a pharmacist's mindset of script-only services to a more collaborative relationship with other team members, for example, health educators, etc.?
Yeah, I think it definitely requires a sit down. I think when you're trying to talk to a pharmacist that's in that dispensing mode by itself, that's probably not going to be a good way to get them to have that dialogue. But I would, be just proactive and call them and set up a meeting to discuss what ways you can collaborate. It's great if it works both ways. A lot of times when I work mostly with pharmacists, and I'm asking them, proactively call a practice that's close to you, or proactively try to integrate into a model. But wouldn't it be great if the practice actually reached out to the pharmacist proactively? Because I think it would shock the pharmacist that's happening in the first place. But it would start that dialogue to be able to brainstorm about ways that you can actually have that happen. So I think the first step is literally just to call them and say, hey, I'd like to meet with you about potentially having a partnership on whatever it is, on blood pressure screenings, on anything you want, referral to our program, education. But that, I think it starts with a simple phone call to be able to do that. One of the groups I participated in with recently was the CDC. They put out a program called PPOD. It was pharmacists, podiatrists, ophthalmologists, and dental, and it was essentially a program that compiled all of these different professionals together so that they could enhance each other's messaging around diabetes management. It was great. What it did is it really highlighted what every other professional's perspective was, and how you could help enhance your referrals or your collaboration with, hey, the dentist if you were a pharmacist, or the optometrist if you were the pharmacist, or vice versa, podiatrist with dentist. But it was to get everybody to message the same and to start collaborating so that you could support the patient with the same message. So I thought that was very progressive and very proactive. And so it, again, just starts with having that communication, a meeting to set something up and seeing where it takes you. I'm not going to say 100%, you'll get 100% response from that, but it's a start, and it will hopefully start getting people to think about engaging in that way.
Dr.
Thank you.
Leal.
So,
Sorry, I have a train in my office. It'll pass in a few seconds.
Let's hope it's not in your office.
It's just behind my office. Sounds like I'm in the train station.
Mm-hmm. So everyone, this is Sabrina, and I did just want to interrupt and say thank you again, Dr. Leal, for all of the ways that you contribute to the Partnership for Diabetes Health Equity. We do have a link to a best practice story from Project Impact that Dr. Leal was involved in at El Rio Health Center, and the PPOD guide is also available on our website in the resource section for free downloads. And I did just want to piggyback on one thing that you brought out is one of the things that we know in dealing with creating health equity is that partnerships and linkages are essential, particularly when we look at our patients who have issues with access. So doing an environmental scan to see who those people are in your environment that your patients need. Many times you can be the first level of contact and of advocacy for your patients. So, and a lot of times people are reluctant to approach community pharmacists or retail pharmacists. They can be a wealth of information for you as a provider as well as for your patients. Many pharmacists, like many of us as providers, got into this because we wanted to make a difference. And so you just leverage what they want to do. You show them how you can work together. They need you and you need them, and at the end of the day, it makes it better for your patients. So that's just my 2 cents worth. So.
Thank you.
Wonderful. So we have a question for both Dr. Leal and Ms. Jackson, primarily because of your work with PDHE, Dr. Leal. How has PDHE used data to advance its work and bring the community and clinic together?
One of the big aspects of the work that we're doing with PDHE, and then just in general, and the other work I've participated in, is really leveraging the data. Like, one of the things that I always tell providers that are starting to practice is, like, look at your baseline values. Understand first of all how to access IT, how to access the reports you need from your EHR, so that you establish what your baselines are for what you're trying to target. And from that, as you're starting to either make an intervention or start a program, see how your intervention is influencing that with tracking. So one of the goals that we've had with PDHE and our participants is for them to be able to do that, to be able to collect data for the population they're trying to serve, and then see how that's tracking over time based on the different PDSA cycles, the Plan, Do, Study, Act cycles, to show that progress and the improvement. So I think that's the way that we're now transitioning healthcare. We're moving into a different model of payment with MACRA and MIPS and meaningful use and value-based outcomes, that if you're not able to successfully do that, that's going to actually have a significant issue around your bottom line. So it's all about really transitioning to that value proposition. And so data is essential. Have a relationship with data. Have a first name basis with your data guy, with your building department. All these different collaborations. They have to be internal and external, so that you can really start having those basically report cards to show the progress of what you're having. So it's not just for diabetes or this particular program, but it's in general the way that I think healthcare is moving now.
Is essential, but it's also terrifying. And so, particularly from a provider perspective, because we don't understand it. It's not what we were trained to do. But as Sandra mentioned, it's where healthcare is going, and in many professions, it's where you're going. You have to demonstrate that what you're doing is making a difference. And so one of the awesome things that we're able to do with our learning collaborative teams is to teach them how to form a healthy relationship with data, who holds the data, what kind of data, how do you get the data, and then what do you do with the data. And we're helping them to unpack that, because as she mentioned, we're all going to have to do it. And so we're fortunate to be able to mentor them through a process of doing that in a safe space. We do hope to begin publishing some of the great things that we're learning and what our teams are doing this fall and then in the new year. So we're very excited about that. And hoping that, there'll be other things that spin off of that, but it's the first step to success, and I'm mentoring people through this new phase of healthcare reform. So.
But we have our final question, and then we will be closing out. The question asks, is there a way that pharmacy students can help some pharmacists with engagement incentives? Engagement initiatives.
Yeah, absolutely. You know, one of the things that I do, I'm a preceptor for the College of Pharmacy, and part of that, what I end up doing is leveraging the students to be the people that do my quality initiatives. So one of my requirements for students that I'm working with is for them to develop a QI project that essentially leads to some publishable impact. It's a very high standard because it's a very significant request, but it's amazing what the students have been able to accomplish. I'll give you an example. One of the things that one of my student groups did is they went out into the community to see how many pharmacists were actually implementing the new regulations around immunization and access for children. And what they identified is that a lot of pharmacists weren't up to date with the change in the law because it happened not that long before that particular survey. But what they were able then to do, the students were they were able to go back, educate these pharmacists on the changes in regulations, and then they went back and surveyed the pharmacists, and they saw an increase in the vaccination rates when they were able to implement these changes in the law. So things like that seem like they can be very kind of like low-hanging fruit, can be very significant in improving access and care. So I always leverage the students to give them an experience that they're going to really learn from, but then also to help us improve quality and different quality initiatives when we have limited resources. So I leverage both. I leverage the relationship and the opportunities I teach to really also enhance my ability to do my job and to do it really, to do quality improvement projects that I might not be able to do because I'm pretty busy with so many other competing priorities, but they are my extensions to be able to do that. So I highly recommend that relationship to try to get students involved, and it's going to be a win-win situation.
Thank you. We have reached the conclusion of our webinar. We thank you, Dr. Yall, for an educational and informative presentation. And we encourage all participants, if you are interested in participating, connecting with the Partnership for Diabetes Health Equity, whether it be sharing best practices, resources, or even sharing the individual story of your organization, we encourage you to connect with us at www.diabeteshealthequity.org, and you can always find us on social media.
Thank you.
And we wish you all a good day.